And I will hand over to our wonderful speakers from aidsmap. I'm going to hand over to Roger Pebody, Gus Cairns, and Krishen Samuel to introduce themselves before we go ahead with the presentations.
Hi, my name's Roger Pebody. I'm managing editor at NAM.
Hi, everybody. My name is Krishen Samuel. I'm a freelance health journalist, and I'm also doing a PhD in public health in the US at the moment.
And I'm Gus Cairns, the other staff editor at NAM.
Should I just explain a little bit about CROI?
Yes. So if you could just do that while my colleague Alex gets the slides set up, that would be great.
So just to introduce what we're kind of covering tonight. I mean, I think in terms of HIV conferences, one that people very often really hear about are the ones the International AIDS Society organise in the summer. And they certainly get a lot of media attention, and there's all kinds of interesting things that happen there. And CROI is a little bit different. It's very much a sort of meeting for scientists and clinicians. It's much smaller, but it really is where a lot of the really interesting research is presented, which is why at NAM we make a real point of covering it quite in depth each year, and we're really pleased to be able to share these highlights with you. I mean, this year I think there's maybe about 3,000 people. It's maybe over half from the US, so there is a bit of a US dominance, but we're trying to pick out some of the things that we think are really useful, either that could affect people's practice, but also just maybe very important to be aware of if you're in the HIV field. So the first section, Gus is going to be covering some of the things to do with cure and broadly neutralising antibodies and vaccines. So some of the more high-level science in that first segment. Then we'll have some time for Q&A. And then Krishen's going to be covering some things on testing and epidemiology, and we'll have some more Q&A. And in the last section, it's a bit of a few things that didn't fit anywhere else. There's some really important stuff about anal cancer, about vertical transmission, and also about injectable PrEP. So that's all I wanted to say, Chan.
Okay, so if you could go to my first slide. Okay, so we plunged straight in the middle of HIV vaccines. There wasn't a lot of news about an HIV vaccine at CROI, I hasten to add. I'm doing this partially because, as Roger says, I tend to cover the highfalutin science, or as I like to think of it, the medically hopeful news in terms of possibly bringing about an end to HIV in medical way, rather than through doing it on a population level. But that does involve explaining certain ideas, I think. So some of this will be more of a tutorial than a news brief. Why have we struggled to vaccinate against HIV, given that we could develop several vaccines against COVID within the space of a matter of months? That's partially because HIV doesn't provoke a natural immune response. It sort of slips into the body in a rather under the radar sort of way. Antibodies are made, and they are the things you detect in tests, but they are too late and they are too specific. And the specificity, we'll see, is very important to stop infection. It's shifty, it changes all the time. That little diagram on the right, the little blob on the left is the annual amount the influenza virus changes genetically within a year in the whole global population. The next blob is the amount a single infection in one person of HIV changes in a year. And the other two are the degree to which it changes globally within a year. So you can see that it's a very it's a virus that changes a lot, and is also sort of subversive. It actually commandeers part of the immune system to act as its own fuel. So we have this paradox that the more activated the immune system, or part of it, gets against HIV, the more reproductive space you have for the virus. Next slide, please. I'm not going to say a lot about these. We've been looking for a vaccine against HIV as long as we've known there's a virus. We did our first big study in 2003. And these are the really large studies that happened up till 2009. Why did we stop at 2009? Next slide, please. Because we had RV144, which was the one and only vaccine that, as of now, in large efficacy studies, has actually shown statistically significant efficacy. And it was a surprise when it came along. It used a particular kind of vaccine that hadn't worked before. And it was only just statistically significant. The efficacy was 31%, which meant that if you took 10 HIV infections, 3 of them would be stopped by the vaccine. And it was only against the sort of weakest, wimpiest viruses. But if you'd stopped the trial at 6 months, you would have seen a vaccine with 60% efficacy. And I think now in COVID, we're getting used to the idea that vaccine efficacy does wane over time, or it often does. And this is certainly the case with HIV. And you can see during the time that the yellow oval was there, then we had what looked like quite an interesting vaccine response. But it didn't continue. The lines became parallel again. They didn't diverge. But it was real. There was a real antibody response. Then we had the challenge of improving it. Next slide, please. It took us till 11 more years to develop a vaccine suitable for a large phase 3 trial in the situation of Southern Africa. And unfortunately, it didn't work. Here you see that the lines which show infections in people receiving placebo and the line in people receiving vaccine were exactly the same. They were more or less on top of each other. The diagram is actually men in the lower 2 lines and women in the upper 2 lines, showing bigger rates of infection for women, as we know. So it was a similar design to RV144. It appears it was overwhelmed by far higher incidence, far higher sort of pressure of different infections coming through, and also viral variety in the South African context. It was like having a machine gun directed at you instead of a pistol, put it that way. Okay, next slide, please. We did have a backup option. This was interesting because it was a study conducted in women only in 5 Southern African countries. And this was a little bit different. It had more variety of HIV proteins contained in it. It was designed to overcome the over-specific immune response. There was a hint of an infect. There were 25% fewer infections in the vaccine arm, but it wasn't statistically significant. This is what the diagram looks like for Imbokodo. Next slide, please. So as you can see, the red dashed line is the number of infections on the vaccine. They're very slightly lower, but it's not statistically significant. It could be a chance effect. Okay, so next slide, please. We still have one large phase 3 trial going with the same design as Imbokodo, but with a slightly broader variety of HIV antigens, which are the substances that the immune system reacts to, adapted for HIV subtype B, the kind that gay and bisexual men and trans women in the higher income world tend to get. It was paused under COVID, planned completion March 2024. Maybe we'll see better efficacy for that. Next slide, please. If there isn't, do we give up on vaccines? No, we don't. There are problems, as I said, with developing a vaccine for HIV. And the fundamental issue is that the virus outruns the body's immune response against it. And we need to turbocharge the immune system with a vaccine. So by the time an HIV infection comes along, it will meet a response that has already won. What I mean by that is, next slide. Well, among the answers we have are these things: broadly neutralising antibodies. And if anything was all over this CROI conference, it was these critters, bNAbs. They're weird antibodies that evolved to indispensable conserved areas of HIV. They only evolve in people who've had HIV for a long time, and by that time, HIV has out-evolved them. But if we could develop a vaccine that would mean that these things were already present in your body before HIV came along, then it might mean you never got infected. The other thing we're using bNAbs for, as you're about to hear, is as medications too, and as possible ways in towards a cure. They're not the only possibility for a vaccine. There's things called replicating vectors, which are the ones that have been used successfully, very successfully in an Ebola vaccine. And of course, the mRNA vaccines, of which we already have two in the shape of the COVID vaccines, the Pfizer and Moderna vaccines. And they tell the body to make the bits of virus that it reacts against, rather than directly injecting those bits itself. Next slide, please. So, HIV isn't just hard to vaccinate against, it's hard to cure as well. It's all this silent, shifty, subversive stuff, and it's also secret. It hides itself. When you are infected, it splices its proviral DNA, its genetic information, into the DNA in your immune cells. It becomes part of their genes, our genes, in a tiny proportion of cells, I should say. And these cells hide because their job is to remember infections. These are the cells that come out fighting when a new infection comes along because a vaccine has primed them. But cells containing HIV DNA only stop under antiretroviral therapy. And if you stop that, you wake up the virus along with the cell. And you'll hear the silently infected immune cells called the HIV reservoir, an invisible presence of HIV in the body, which comes back when you take off the pressure from drugs. Next slide, please. But we do have people who are cured from HIV, and more than you might think. The two that most people have heard of are Adam Castileo and Timothy Ray Brown, who were cured with bone marrow transplants. We had another one at CROI announced, who I'm going to show in the next slide. But there are others who did something rather different. There's this woman called Lorraine Willenberg, who apparently has managed to purge all the HIV from her own body with her own immune system. And there's another woman in Argentina called the Esperanza patient. Even more excitingly, I think, there's another woman, coincidentally in Argentina, who never was somebody who had a very low viral load, but actually had quite a severe HIV infection, but who came off treatment and the virus never reappeared. We don't know how she did it. We're trying to find out. Next slide. So this was the biggest story at CROI. It was all over the New York Times, amongst other things. I've chosen the New York Times page because she came from New York. A mixed-race woman, postmenopausal. She had HIV in 2013, leukemia in 2017, and she needed a stem cell transplant. Those are these progenitor immune system cells. They're in the bone marrow, but they're also in placental and umbilical cord blood in newborns. She needed a transplant for leukemia. Basically, stem cell transplants replace your entire malfunctioning immune system. This is called engraftment. And with Timothy and Adam, our two previous men cured, that was replaced with cells immune to HIV. But these are very rare in non-white people, and this was a mixed race woman. So they used a mix of cells immune to HIV, stem cells immune to HIV, and stem cells that weren't immune to HIV from a relative. And these sort of acted as a sort of friendly environment for the cells immune to HIV to replace the cells that were permissive to it. And this was achieved in a remarkably short 100 days. And she's now been off antiretroviral therapy for 14 months with no sign of HIV. That's perhaps a little early to definitely consider her cured, but they can't find any in her system. But interestingly, next slide, please. We had another study that wasn't nearly so fated, which was of someone who had managed to save for 3.5 years of antiretroviral therapy with no rebound. Why wasn't this as fated? Because it was a different technology. Okay. This person was treated with bNAbs, broadly neutralising antibodies, plus an immune booster. Okay. Now, after 400 days from the start of study, people were asked if they wanted to stop the antiretroviral therapy. 20 did. 7 managed to stay off antiretroviral therapy for 3 months without having to restart it. But 1 stayed undetectable. And as of now, is 3.5 years off therapy with no sign of their HIV reappearing. How do they do it? They feel that the antibodies must have primed their immune system to be hypervigilant against HIV and contain the little bit of HIV that he still has in his system, because it was a guy in this case. Next slide. So I think the reason he wasn't fated is there's rather two different concepts of cure. One is complete elimination. You'll hear this weird term sterilizing cure, which simply means they've cleaned the body of the pathogen, of the germ, but it doesn't mean it makes you sterile. So that's the removal of every HIV positive cell in the body, like a cancer cure. Okay, that's risky. Timothy Ray Brown in particular was made very sick by his cure. It's expensive. There are more subtle ways to do this. You can use genetic engineering to snip out the rogue HIV DNA and sometimes to replace it with more healthy DNA. This has been done for other diseases, most notably recently for spinal muscular atrophy in kids, a very rare and distressing genetic illness. This is unbelievably high-tech science. It's unbelievably expensive. I checked it just before I came on, and this costs $2.1 million for a single dose. Right, okay. Nonetheless, undaunted, the Gates Foundation is funding an institute in Uganda alongside a couple of American institutes to try and find cheaper ways of doing this. But there is also remission. This is much more like what happens a lot of the time in cancer. The idea is to drive down levels of HIV so far that the immune system can contain it, and our hope is to contain it forever. In some cases, this can be done with very early treatment. There were a couple of studies I haven't had the chance to put up in this slide deck of kids, little toddlers, who were treated very, very early, some with broadly neutralising antibodies, some with regular ART, and they appear to have become HIV negative and to have at least got a period of grace off antiretroviral therapy. Some people have done this naturally, as I say. Maybe others we don't know about who are still antiretroviral therapy. It's less risky and expensive, but when is a remission a cure? Will it last forever? And there is pre-existing resistance to some of the antibodies that may keep HIV in check. Next slide, please. And this is what I mean by resistance. Broadly neutralising antibodies are not a miracle drug, anything more than anything else is. They're just big protein molecules rather than small molecules. This is another study of people who, there were two parallel studies, two different studies of people who were put on cocktails of, in this case, 2, and in the other one, 3 broadly neutralising antibodies. In this case, 4 out of 6 people, their viral loads came back quite fast and they had to go on antiretroviral therapy. That's the bits in the grey. And they were very resistant to the antibodies, or to at least one. The white cells show total antibody resistance. But the other 2, who were not resistant to the 2 antibodies, one stayed off antiretroviral therapy for 16 weeks without becoming undetectable and chose not to go back on, as it happened. The other has stayed off for about 8 months now with no sign of their HIV coming back. Next slide. So that's, I think, where we're at with cures. I think the promising thing is that we are developing a number of different approaches to the idea of curing HIV and also of vaccinating against it, because the 2 technologies will be similar. So I'm probably way over on time, but if you've got any questions, now's the time to ask them. There's a lot to understand, I appreciate.
No, actually, Gus, we're bang on time, which is really great.
Fantastic.
So if anyone has any questions, feel free to drop it in the chat or in using the Q&A function. I think one thing for me, it's really exciting, all of this, the cure findings, and I think probably what's more accessible is this idea of functional cure and long-term remission. But how far are we really from that maybe becoming an option for people? Is it really far away?
I think the story of the vaccine shows us that HIV is a very wily foe and has all sorts of answers to attempts to get around its presence in the body. But there was definitely a sort of, it's very early science. This is sort of lab dish monkeys, very early studies in humans. There was definitely a feeling I felt at this CROI of a much more sort of variety of ideas about curing HIV, and some results in humans which were actually quite exciting. I think The big problem is HIV's genetic diversity. You need something that can overcome that.
Definitely. Any questions from anyone? Okay, we will have other opportunities throughout the session, so you can just drop them in whenever something occurs to you. And I didn't say this at the start, but the slides will be available afterwards, as will the recording. So now I just will hand over to Krishen, who's going to go through the next section.
Thank you, Shamush. So I will be starting with a study that was presented by Dr. Singh and colleagues from the US CDC. And this study looks at the period 2017 to 2019 and looks at HIV lifetime risk. It compares this period to an earlier period from 2010 to 2014. We see that in 2019, there were approximately 1.2 million people living with HIV in the US and around 37,000 new diagnoses in that year. Now, the overall lifetime risk has decreased by 11% when comparing these two periods. And the new estimate is 1 in 120. However, we see that there's been no improvement in HIV risk for certain groups, such as Latinx populations, American Indians, and white females. And we also see that there are still stark racial and geographic disparities in terms of HIV lifetime risk. So for instance, Black males have a 6 times higher lifetime risk and Black females have an almost 12 times higher lifetime risk. If we look at the graphic here, we see that in terms of where you're located in the US is also really important. We see that many of the southern states carry the highest burden. And in fact, these are many of the states that are currently being targeted in the US. In the US currently, we have something called Ending the HIV Epidemic. And this aims to reduce the number of new infections by 90% by 2030, specifically focused on these southern states where transmission is very high, especially among certain populations, such as among African Americans. So we can go on to the next slide. If we look more closely at sex and race differences, we see that overall risk for males is much higher than it is for females. On these graphs, the shorter bars indicate a higher lifetime risk. We see that once again, there's a definite racial pattern here. We see that it is highest among Black and Latino males and females, and lowest among white and Asian males and females. In terms of changes when looking at the previous period, we see that there's been a much larger reduction for white males and no change for Latino males, only a slight reduction for Black males. And what is interesting about these racial patterns is that we see them in various different contexts. So even in the UK, we see that while there's been a reduction in incidence for certain groups, it's not reducing as quickly for certain racial groups. I will point out that with this particular analysis, there hasn't yet been a subgroup analysis in the US looking specifically, for instance, at Black men who have sex with men. And this is, of course, important because according to some estimates, they have a very, very high lifetime risk. Some estimates suggest 1 in 2 chance of contracting HIV within their lifetime. Next slide, please. So if we compare this to HIV diagnoses in England, we see that in the UK as a whole in 2020, there were 106,890 people living with HIV, most of them in England. And in terms of who's going undiagnosed, approximately 4,660 undiagnosed people in England for 2020. Now, between 2019 and 2020, there was a 33% decrease. But when looking at this decrease, the important question, of course, is this a true reflection of a decline in incidence, or is it as a result of less people getting tested for HIV? So this is really important to look at, and I do have a slide on testing a little bit later on. For men who have sex with men, this definitely seems as though it's very much linked to a true decline in incidence, because as you will see that there's been a very small decline in testing, but a 41% decrease from 2019 to 2020. However, once again, we see that this is less apparent for certain groups. So for men who have sex with men living outside of London, Black, Asian, mixed, and other ethnicity groups, as well as those born abroad, we're not seeing as much of a decrease in incidence. In terms of heterosexuals, there's been a 23% decrease, but as you'll see on a later slide, there's been a much bigger decline in the number of heterosexuals getting tested for HIV. So we do need to interpret that with caution. Next slide, please. So how is England doing in terms of making progress towards the 95, 95, 95 targets? And that is that 95% of those living with HIV are diagnosed, 95% of those diagnosed are on treatment, and 95% of those on treatment are virally suppressed. England is doing incredibly well. All of these targets have been met. And according to the 2020 statistics, we see that 91% of all people living with HIV were virally suppressed. Next slide, please. The next study that I will present is some research by Dr. Drumme and colleagues from the CDC. And this looks at PEPFAR data from 41 countries. Now, PEPFAR is currently active in 55 countries globally, but these 41 countries, this data comprises approximately 99% of all of the PEPFAR data on HIV testing and treatment. And what we see here is that there was a decline in the absolute number of tests done. And this is partly because there was a change in testing guidelines in 2019. So what we see is that, if you could just click next, please, we see next again and again. Thank you. We see here that there was a 42% increase from March 2016 to a peak of 27 million tests in September 2018. However, once the guidelines were changed, and what the change here is moving away from universal HIV testing towards more targeted testing based on risk profiles, based on index testing. And so we see that then the number decreased by 42% to 16 million tests in December 2019. By June 2021, there were approximately 15 million tests being conducted. Now, if we look at the number of positive tests and we look at the percent positivity rate or the yield, which is the number of positive tests divided by the total number of tests, we see that this came down from a high in September 2017 of just under 1 million to and decreased to about 600,000 in June 2021. And we see that essentially the percent positivity rate has been fairly stable at around 4% since December 2019. The question here, and there is some controversy over this policy decision, because the question here is, does this reflect a true decrease in incidence in these countries, or is it that more people are actually going undiagnosed? And further studies need to be conducted to really tease this out. And next slide, please. So here we see that there is quite a good success story. And this is related to the number of people who've been testing positive and then are linked to treatment subsequently. Unfortunately, COVID-19 did affect this somewhat. It came down from a high of 97% in June 2020 to about 94% in June 2021. But if we think of the number of countries that PEPFAR is active in, and as I mentioned, this is accounting for approximately 99% of PEPFAR data, a proxy linkage rate here of 94% is very high, and it is very good. It means that we're seeing that the vast majority of people who test positive are being linked to treatment. Next slide, please. So if we look at HIV testing in England, as I'd mentioned earlier, we've seen this decrease in the number of new diagnoses between 2019 and 2020, but we've also seen quite a large drop in terms of HIV testing. So this drop was much more pronounced for some groups. For men who have sex with men, it only fell by 7%. And in fact, that number of tests done was still higher than 2018. There were also still quite a few frequent testers, probably men who are on PrEP. However, for heterosexuals, this fell much more sharply. So there we see a 33% decline in testing. And if we look specifically at groups such as Black African heterosexuals, we see a 34% decline for men, a 24% decline for women, and white heterosexuals, a 43% decline for men and a 30% decline for women. So this is a concern. I think here the important question really is, how do we target those who are still going undiagnosed? And I don't think there is a straightforward answer to that, but it is going to become more of a challenge as we progress and as we get closer to those 95 targets, or in England's case, they've already been reached. How do we target those who are still going undiagnosed? Next slide, please. So another success story here in terms of England is if we look at the undiagnosed prevalence for the period from 2013 to 2019, we see that this is halved. And this is really great because we do see that there has been progress in getting to some of those harder to reach populations. As we can see in all of these different subgroups, we've seen a reduction in the number of undiagnosed people. Next slide, please. Another study that I'll point out from CROI was a poster presentation by Dr. Cambiano and colleagues, and Gus was one of the co-authors on the study. And this study was really just looking at what are those factors that have contributed to the decline in incidence among men who have sex with men in England. So if we compare 2021, around 670 infections among MSM, and we look at in 2011, there were 3,000, that's a 75% reduction. So in terms of the success story, the question here really is which prevention mechanisms worked and which ones worked very well. And as we would all imagine, the answer is that it's a combination of the strategies that worked really well. But if we go to the next slide, we see different counterfactual scenarios. And in each of these counterfactual scenarios, the effects of one form of prevention are isolated and then compared to an earlier period while keeping the effects of other types of prevention stable. So for instance, if condom use had not increased beyond 1980 levels, they were only around 10% among MSM at that time, but all of the other factors had remained the same. So in terms of HIV testing, PrEP, treatment as prevention, then we would have had 115% more infections by 2021. And you can look at the different scenarios. I will mention that in terms of looking at treatment specifically in the counterfactual scenario here, it looks specifically at treatment guidelines changing for treatment only being started when the CD4 count went below 350. But as we know, of course, people living with HIV were on treatment for much longer than just since 2012, and many of them were virally suppressed. But nonetheless, what this does point out is the synergistic effects of combination prevention, because we see if none of these interventions had occurred, there would have been over 7,600 in new infections in 2021. What's also really important to point out here is that these strategies work, they work well, and continuing with these strategies will lead to virtual elimination of HIV among men who have sex with men in approximately 25 years in England. So it's really great, you know, for me here in the US, it's great to see such positive data from a country with a very, very well-managed epidemic. However, as I mentioned, we're still seeing those racial disparities in different contexts, both in the US and in the UK. That brings me to the end of my presentation. I'll be happy to take any questions.
Thank you so much, Krishen. That was really, really interesting. I think there's a question that's just come through. Let me just pull it up. Okay. So, what were the references?
Sure. So on my slides, I have included references. So if the slide deck is shared, then the references are actually in the notes for each of the slides.
Great.
And maybe afterwards we can also circulate a list with, it will be the links to all the articles where we discussed on aidsmap, and it always includes the full reference as well. So yeah.
Brilliant. Okay. And yes, the slides are going to be circulated. So I just thought that was interesting. Maybe while people are gathering their thoughts about that, some things that stuck out to me. I think I was interested in the source of the US data. Is that national surveillance data, or was that some research?
That's national. That's national surveillance data. Yes.
And do they disaggregate by sexuality? Do they do that subgroup analysis over time, or?
They do. So for the 2010 to the 2014 analysis, we saw that they did actually look at the specific subgroups. And that's where that statistic for Black men who have sex with men comes from, the 1 in 2 chance, 50% lifetime risk chance. It just hasn't yet been done for the 2017 to 2019 data, but this is something that they do need to do, because as we know, of course, we can look at the data in terms of just race and just sex, but when we look specifically, for instance, if we look specifically at Black transgender women, we know we're going to see a very different pattern there. So that subgroup analysis is very crucial.
Absolutely. I think particularly from an England context, I think having as much detail in the data as possible has really helped us be more targeted in a more effective way, and also being aware of the different groups that we need to bring along, particularly as we start to see more and more disparities between those outcomes before different groups. I thought it was really interesting about PEPFAR as well. I mean, slightly disappointing about that policy change, particularly because when you see in that chart, actually, the number of tests, actually a very high positivity rate still at the peak of that, but very promising, very encouraging how much they've managed to increase the uptake of ART and the linkage to care. In light of your last slide, talking about combination prevention, it also really helps to reinforce. I think for me, the early initiation of treatment has been one of the most powerful things. I think something that I hope we can sort of bear in mind, because I think working in the prevention space, sometimes it seems we talk about combination prevention, but sometimes, we know whether it's about PrEP or, everything has its own pros and cons, and looking at how altogether it's had such a powerful systematic change is great to see. Okay, now I'm just looking at the chat. I think there's one, I don't know, it's just a comment. Very interesting, the idea that so many more queer men would be testing positive without all of these interventions is inspiring, and we prevent thousands of queer men from becoming infected. Yeah, I think the changes, the reduction in incidence among gay men has been really, really amazing. It's really worth celebrating, and now we just hope we bring everyone else along for the ride. I don't know if you had any other comments or observations.
I see that there is one other question, which I'll just quickly try and answer. And this question is, what are your thoughts on why HIV transmission is higher in southern states in the USA? And that's a really great question. I think we're becoming a lot more aware of the fact that racism and not race is a risk factor for negative health outcomes here in the US, and we're becoming a lot more aware of some of those systemic barriers. So for instance, another study that I covered on aidsmap just earlier this year showed that Black people in the US are actually less likely to be prescribed PrEP, even when they meet the eligibility criteria. So really what we're talking about are these systemic barriers, and we see that these systemic barriers are present all along the HIV care continuum. And so if we're speaking specifically about southern states, we really need to be understanding those systemic barriers, those racial inequalities, and how they contribute to higher levels of HIV incidence for vulnerable populations.
And is that something that you see being covered, in a systematic way? Because I think one of the challenges we found is in terms of gathering that data to inform any kind of system changes can be challenging.
Absolutely.
As well.
I think that Absolutely. I think that there's a growing awareness of the fact that we need the research, we need the data. You know, we can't speak about the racial disparities unless we have the numbers to back that up. And then once we speak about the racial disparities, we need to understand the mechanisms behind those racial disparities, what is driving that. And that really does come from the research. We need to understand how this is happening and how it contributes to higher incidence in certain groups. And I do think there's definitely a lot of growing awareness among researchers, among scientists, among public health professionals regarding that. So I definitely can see that. And we do see with the ending the HIV epidemic, which I mentioned, there is this focus on the southern states, and it is looking specifically at these racial disparities and these vulnerable groups, such as Black men who have sex with men.
Amazing. There's a bit of a discussion happening in the chats. A comment from Helen, wondering about the additional link of poverty with racism. And a comment from Gus around how PrEP was what also had such a huge impact. So yeah, I think that's great. I think let's keep the discussion flowing. It's great to see everyone so engaged. Thank you so much, Krishen. And I think next it's going to be Roger with the next part of the presentation. So I'll let you take it away from here.
Cool. Thank you. So I'm going to talk a little bit about a big anal cancer study. I mean, we're mostly trying to cover issues that are related to prevention in this webinar, but in terms of the sort of big news, in terms of other health issues that particularly affect people with HIV, and also again bisexual men in the UK, anal cancer is a really important one, and this was the one study that will really change clinical practice, I think, in terms of comorbidities that was presented. So just to give some background, anal cancer is relatively uncommon, but it is a lot more common amongst people with HIV, especially older gay and bisexual men with HIV. And in some ways, I mean, it's quite similar to cervical cancer in the sense it's the same virus that is the root cause of it, HPV, and you have these stages, which I try to illustrate there, that you've got HPV infection, which is incredibly common, and for most people is doesn't cause any harm. In a small number of people, that goes on to cause precancerous lesions, and HSIL is the sort of the technical terminology for them. And then in a very few people who have HSIL, it goes on to cause anal cancer. And in cervical, in the cervical sphere, we know that screening helps prevent cervical cancer. So you might think that it'd be logical that screening for anal lesions would help prevent anal cancer, but basically there wasn't any evidence to show that until this conference. Next slide, please. So into the, well, why would you need to do a study? I mean, it was the guy who presented on this study really talked through what were the issues that meant that it was worth researching, that you couldn't just decide to provide anal screening for everyone anyway. And these are really listed here. And basically, the screening is quite hard to do. You don't necessarily pick up all the cases. When you try to treat it, you don't necessarily treat all the lesions. And then some new lesions seem to pop up after you've done some treatment. So there was some real genuine doubt about whether this was something worth doing. Next slide, please. So this is the way the study was organized. It was a very large randomized study, all in the US, big cities in the US, but over 10,000 people with HIV took part in the initial screening. Everyone was aged over 35. You know, as I noted earlier, anal cancer is something which is much higher risk as we get older. And everyone at the beginning of the study was offered two types of screening: cytology, which is like a pap smear, which is the older technique that tends to be used for cervical screening, and anoscopy, which is basically a small magnifying device that goes up your anus in order to look for anything that's wrong. So the randomization happened after that. So anybody who was identified as having these precancerous lesions was split into two groups. One group was immediately treated, and the other group would just had follow-up screening 6 months later, and then 6 months after that, and 6 months after that. So the real intervention was actually offering immediate treatment. Anybody who had anal cancer was treated, of course, straight away. And what they were looking for in the study was a difference in rates of anal cancer. Next slide. So these are the results. The first, those numbers there on the left, I think this is kind of one of the important things is actually to note how many people taking part in this study had these precancerous lesions. And okay, to some extent, you'd expect people who are choosing to take part might have a concern about this, or their doctor might have thought that they'd be the right kind of person. But it's so it did largely recruit gay men. But what's really noticeable there is 46% of women who were recruited had these lesions, and that was much higher than anyone was expecting, and obviously a very high rate there amongst transgender people. And there were a number of cases of anal cancer. I don't think that was a particularly high figure, which just is somewhat reassuring to show that it does remain a relatively rare outcome. For once, I think it's really worth looking at the graph on the right here. And what you're seeing there are the number of cases of anal cancer. And the blue line is the people who were put into this monitoring group who didn't get the treatment immediately. And the sort of red-brown line are people who got the immediate treatment. And the fact that these lines are so divergent shows there was a big difference. Basically, there were double the number of cases of anal cancer in the monitoring arm, showing that treatment, immediate treatment is definitely worth doing. So next slide. So, I mean, the implications of this really are that treatment guidelines should be changing. The problem with this is there isn't enough resource around, there aren't enough clinicians who know how to do this procedure well, and it's not an easy one to learn. So there was some discussion in the meantime, before maybe there are enough clinicians to do this. And one of the recommendations was about prioritizing anybody who's got symptoms, got lumps, pain, bleeding, and also older people and people with low CD4 counts, who are people more vulnerable to anal cancer. Next slide. And the other really important point is, and I think I saw someone raise this in the chat earlier on, is Hpv vaccination. Clearly, it's much better never to get these lesions, never to need to have these invasive procedures in the first place. And I think it's just a reminder of why this is something that we should all be trying to make sure everyone who's eligible gets access to it. It's of course recommended for 12 and 13-year-olds across the board. Most adults will have missed that, most adults today. So BEVA does recommend it for most adults with HIV. And there's also a program in sexual health clinics for HIV negative gay and bisexual men. So it is something that's available. Let's move on, next slide, to a different topic. So there's some really encouraging data on vertical transmission, in other words, mother to child transmission from France. I mean, it's a country with a very similar health system to ours, and I have seen some good data from the UK before, although not quite presented in this way. So the researchers in France looked back at all their cases of HIV positive mothers since between the year 2000 and 2017. And there were two specific groups where the transmission rate was 0%. So it's important to say this is not all women living with HIV, but in these conditions, there were no transmission, and there were thousands of women in each of these two groups that I've marked up here. So the first one are women who were already on HIV treatment before they became pregnant. they had an undetectable viral load at childbirth, and they didn't breastfeed. And the other one is women who got to an undetectable viral load in the first trimester, in the first 3 months of pregnancy, and also didn't breastfeed. So I don't think we're yet at a stage where we can really talk about U equals U necessarily always applying in vertical transmission, but this is perhaps some of the first data that might get us towards that kind of place. And next slide. So also from, I mean, those were the really encouraging bits from that study. Just to highlight, I mean, they really saw the rates going down over that time of the study, from over 1% at the beginning to 0.2% towards the end. And it's quite clear the circumstances in which transmission does happen is mostly when there's been no antiretrovirals at all. That's the really important one. But also starting treatment later in pregnancy, slightly higher viral load, such as over 200, for example, and also premature delivery. So I think I've probably come to I'm going to pass things over to Gus now. We can move on to the next slide. Yes, this is Gus's slide. So he'll pick things up for the last bit.
Yes, I'm back for an encore. Okay, right. This is Injectable PrEP, which has been a really interesting topic, and one that people are very interested in. The major news on injectable PrEP happened last year. At this time last year, we learned from this study, the HPTN-083 study, that if you gave people once every 2 months injections of the drug cabotegravir, that prevented 2/3 more HIV infections, or to put it another way, it reduced the risk of HIV by another 2/3 compared with taking standard PrEP pills on a daily basis, which is in itself quite a remarkable result. We also heard later on last year from HPTN-084 that the risk was even more greatly reduced in women, to the extent of about 80% reduction in risk. And I'm expecting further results from that in the summer, possibly at the IAS conference. So this was, at this conference, they presented another year's worth of data from an open label study that happened after the main study, which was randomized. In the randomized part of the study, people either took cabotegravir injections plus a Truvada placebo, or they took placebo injections plus Truvada pills. In the open label study, they were basically all put on cabotegravir injections. So that's where we are with that. And the really good news, next slide, please, is that it didn't affect the efficacy generally at all for the study to go open label. Incidence, the number of HIV infections per year did increase, but it increased in both arms. In other words, if you put people on an open label study with perhaps less monitoring and less sort of attention than there is in a randomized scientific study, adherence tends to go down. People forget to take their pills, but also they may not turn up for their regular injections. What we have then is an HIV annual incidence of 1.57% a year in people on Truvada and 0.54% a year in people taking the cabotegravir injections, and that translates to, well, 0.34 incidence rate ratio, which translates the other way around as a 66% efficacy. In other words, 2/3 more infections were stopped by the injections than by oral PrEP, which of course doesn't mean that the oral PrEP wasn't also stopping infections, just not as well. Okay. So that's the good news. We're now 4.5 years into this study, and we haven't shown any sign of the relative improvement in offered by the injections going down. Next slide, please. However, there was presented more of an analysis of some of the infections where in people allocated originally to cabotegravir, nonetheless, they became infected. There weren't a lot of these, There were 9, 10, 11, 12, 16 people altogether. These are, I should say, only data from the randomized part of the study. The open label study, they saw a few more infections, as you might expect. So in these 16, 4 of them already had HIV at the start of the study. That was not detected in time, and they went on to the study already having HIV. This is a problem in prevention studies. 5 of them were people who just basically stopped taking their PrEP, or in one case actually switched to Truvada because the injections didn't agree with him or her. 3 caught HIV during the oral lead-in. There is a period of about, I think it was 4 weeks or 5 weeks, when people were on cabotegravir pills instead of the injections. That was simply to make sure they didn't get weird side effects from cabotegravir, because if you get an injection, you can't get it out the body. So they were essentially on oral PrEP. But that left 4 where they caught HIV despite apparently good adherence to the injections, satisfactory drug levels in the body, and we don't know exactly why. So cabotegravir is not completely foolproof necessarily. We don't know why. Maybe in some people they develop rather lower levels of drug in the body than most people do. And I should say that in the open label year of the study, we spotted 3 more of those infections. As part of this diagram also, another presentation found, however, that we could have at least detected these unexpected infections a lot sooner if we had given people PCR, in other words, viral load type tests instead of HIV antibody tests. One of the problems with PrEP is that if you catch HIV while on PrEP, PrEP will kind of half work. This means, firstly, that the HIV may have a very low viral load. You might not get antibodies to it. You might find it very difficult to test for. And secondly, you may well develop resistance, because the classic way to develop resistance to a drug is to take some but not enough of it. And that's what happened indeed in another study that they found. Most of the resistance could have been avoided if people had been given PCR, i.e. viral load tests, on a fairly regular basis during the study, rather than standard HIV antibody tests. But that would make injectable PrEP rather more expensive. Okay, that's all I want to say about injectable PrEP, other than one thing that isn't here in the slides, which is, when are we going to get it? It's been approved by the US FDA. It is starting to become available in places like Canada and so on. We already have cabotegravir and rilpivirine injections approved for HIV treatment. They're expected imminently in the clinics. But so far, we've heard nothing from the European Medicines Agency or the UK regulators, whose name I can never remember, Alex will know, about approving cabotegravir injections for PrEP. So I think if any of you are in a position to make sure that that gets approved, please pull whatever strings you can, because this makes a huge difference to the risk of HIV infection. And that's, I think, me. It is.
Brilliant. Thank you so much, Gus and Roger. That was really, really interesting. And I think lots of discussion in the chat, a few questions coming through the Q&A function as well. I think just going back sort of according to how different topics that you covered, I understand there were lots of different bits to look at. Just one thing for me on the Anchor study, there were 10,000 participants, just a clarification, and about half of the men, half of the women had the precancerous lesions. Is that of everyone who had precancerous lesions, or was that everyone who participated?
So actually, no, can you ask the question again?
So in terms of was that of everybody who had precancerous, or was it of all the 10,000 people who were enrolled, about half of them had precancerous lesions?
Yes.
That's exactly. That seems like a lot, really high volume. So do you think, in terms of people working in the HIV sector, working with people living with HIV, do you think there's something around that we maybe need to think about more around this area? Because maybe it's not something that I personally have heard commonly spoken about. Is this something we need to talk about more?
Yes, I think so. I mean, I think I'm pretty confident that the BEVA will be thinking about the guidelines that they recommend and about how services can scale up to offer this, because as I understand it, it's something that a few clinics have been offering for a little while, and they've generally been doing it on a kind of basis of, we think this is almost certainly a good idea, although we haven't got the evidence. But at the moment, I imagine in many parts of the country that those services aren't available, and there's probably, I'm not sure that many regular patients are asking their doctors about this at the moment.
Thank you. That's really, really helpful. Right, so now we'll just go into the questions. Questions around the HPV vaccine, but I think that's just a discussion. Vertical transmission and U equals U. Is there anything about that relationship, or do you know of any, maybe it wasn't covered in CROI, but any studies looking at that? Because we know it's usually referring to sexual transmission.
Is this the question about breastfeeding, or?
Yes.
Yeah. So I think someone said, can we say U equals U for breastfeeding? And I think at the moment we'd definitely have to say no, just because there have been a handful of documented cases of transmission from a mother who was undetectable and did pass on to their infant. So obviously the whole point about U equals U is to really talk in absolutes. So, whilst it's really clear there's a really close relationship with viral load, and undetectable viral load will, really prevent the vast majority of potential transmissions in breastfeeding. The figures are very, very low. There are some that happen. I mean, current advice from BEVA is to say to mothers that the safest way is to use formula feed. However, there is an understanding that for many women it's something that is important, and there may be all kinds of cultural and social reasons why using formula feed doesn't feel appropriate or possible in some cases. And so their advice is, if breastfeeding is going to happen, it really needs to happen with a lot of regular monitoring to really check that mother is still undetectable, and awareness of other health issues that could raise the risk. So that's sort of stomach problems in either the mum or the infant, or any sign of infection of the nipples. But
Gus, please go ahead.
Couple of things. I mean, firstly, there was a study at the European AIDS conference presented in October from Switzerland, where there was they surveyed a bunch of women who were breastfeeding about whether they'd be willing to breastfeed or would prefer to stick with bottle feeding. And really, I think the sort of weight of opinion is swinging in favor of breastfeeding in situations where women can be assured of antiretrovirals. Ironically, in situations where they can't be reassured of antiretrovirals, they're the kind of countries where actually breastfeeding is still nonetheless safer because of issues to do with water supplies, etc. So I also want to talk to Helena, who also asked the question about PrEP. And she says, do we know why the injectables had a better success rate than tablets? Is it a simple case of adherence? And the answer is yes, basically. There was, in the whole study, including the open label study, there were 72 infections in people allocated originally in the randomized part to Truvada, and 25 in the people allocated to cabotegravir, right? So its advantage persists, and it is entirely, I think, driven by adherence. It just seems to be easier to turn up for a once every 2-month appointment than to remember to take your pills every day. Some people, on the other hand, may manage that, okay? You also ask, is there anything about treatment failure when it's used as treatment? And the answer is yes. These are not completely foolproof. And I think I said something about in people who had HIV infections on PrEP and took the cabotegravir injections, nonetheless, cabotegravir resistance did happen in the majority of those people. And they have seen resistance to this drug happening in people who take it as treatment and who, for one reason or another, maybe have pre-existing resistance or misappointments or whatever. So like any other drug, this is not a magic bullet, but it's very, very good at preventing HIV.
So are we, just on the topic of resistance, Dano, is that something that came up at the conference? Is that something that, you know, as we move more towards these modes, or, you know, injectable PrEP, or, you know, more PrEP, whether that's tablets or other forms, you know, is that something that you think is going to be a concern? Maybe not now, but maybe in 5 or 10 years, you know, is that something we need to start thinking about?
Shall I answer that one as well? Yeah, okay. Well, I think we're at different stages with different drugs. I think with the integrase inhibitors and some of the protease inhibitors, which may have side effects, we're talking about some quite resistance-proof drugs. Resistance doesn't arise easily. When it does arrive, you often get a crippled virus, which isn't very good at circulating. So actually catching resistant HIV is really quite rare these days. So that's good. As I say, the big Achilles heel of the brand new antibody-based therapies is that at the moment, there's a lot of pre-existing resistance around, and we may have to devise ways of manufacturing or getting the body to manufacture quite whizzy high-tech antibodies that HIV finds it less easy to become resistant to. Okay, but I mean, there were fears when PrEP started that would give rise to a lot of extra resistance, but it hasn't done as far as we can tell. The main driver of resistance is suboptimal amounts of HIV therapy, sometimes because of poor adherence, sometimes because of poor access.
Great. And I'll just give people just a chance. If you have any last questions, just drop them in the chat. And one thing that I think I'm amazed we managed to go the whole time without mentioning was COVID. So I'm sorry to bringing it in at the 11th hour, but I mean, was there anything, whether that's in terms of, you know, COVID's acceleration of vaccines, or, you know, other ways that it's influenced different parts of different research projects happening? Was there any like really key highlights that came out with some of that work that might be happening in parallel or specific to HIV?
I mean, I think there was some stuff about booster vaccines, because obviously they've only been deployed in the last few months. So this was really one of the first opportunities to hear about whether booster vaccines have been working well in people with HIV, and they have. There was a fairly reassuring study showing that rates of COVID vaccination in the group of people with HIV they had in that study were high. They were a little bit higher than the general population in the countries that they looked at. But I would say we didn't really focus on the the COVID only. We were very much looking at COVID, how COVID and HIV interact, but the doctors at that conference, most of them have been doing massive amounts of work on COVID. And I think there is all kinds of stuff from COVID that is feeding into the HIV work and sparking ideas. I mean, that might be something that either Krishen or Gus want to say more about.
I think I just want to mention that there are ongoing concerns, obviously, just in terms of people getting access to HIV testing, getting access to their medication, and how COVID has impacted upon that. And then, you know, just to touch on what Roger's just mentioned, you know, many of the infectious disease experts, many of the researchers and so forth are now focusing largely on COVID. So I think there is this kind of question in terms of, and this is quite a broad global question in terms of the global HIV response losing some of its momentum as a result of the other pandemic. And I think it is an important point for us to kind of keep in mind, I guess.
Mm. In terms of the actual risk of COVID to people with HIV, it's I think it's pretty well established now that if you have uncontrolled viremia, or if you have a low CD4 count, then your vulnerability to COVID and COVID illness is greater. But that would be the case if you had factors that reduced your immunity if you didn't have HIV as well. But it does seem, as Roger's been saying, that there is relatively reassuring data about the ability of people with HIV to respond to the vaccines. And I think Krishen is right, but there have also been some studies showing improved rates in some parts of the world of HIV treatment during the COVID era, interestingly. And so it's a mixed picture, because in some parts of the world, rather than services necessarily being neglected, they adapted to do things that they maybe should already have been doing, like home testing, for instance, and things like that. So it's a very mixed picture. I should be interested to see what happens in the the post-epidemic period, if that's not too rash a phrase.
Brilliant, brilliant. Thank you all so much. Yeah, I was just about to close, but I've just seen a question from Vicky talking about the fourth COVID jab. So some people living with HIV have already had that. How does that work with latest JCVI advice for a fourth jab this spring? Does that mean they get a fifth? So I'm not sure if you'd be aware about any of this, or maybe that's probably that's probably a question for Biva to answer.
I would, yeah. I'm not feeling confident to answer that correctly.
Yes, Vicky, we'll get back to you. We'll check with colleagues at Biva and let you know. Yeah. And yeah, I think any last words, any last thoughts? I think we're just about ready to wrap up. Oh, okay. Thank you all so much. That has been really lovely. Some lovely feedback coming in through the chat. Thank you all so much. You have really been able to translate something that I have to confess, I was always a bit scared of CROI. I thought it was so technical and seemed a bit inaccessible, but you've really broken it down and it's super interesting and useful. And I can really see how it could apply in terms of some of the work we do day to day, in terms of the priorities, in terms of the focuses, in terms of the things we need to bear in mind, not just from a scientific or biomedical perspective, but also from a community perspective and access perspective, and inequalities perspective. So that's been really useful, really interesting. And I've enjoyed having this webinar with you all. Thank you all so much. And thanks as well to all of our participants and attendees, on a late afternoon. Appreciate you giving your time. So do join us. We hope to have more webinars like this in the future, together and on different topics. So I know my colleague Alex dropped the survey link in the chat. If you don't mind spending just 5 minutes so we can make sure our webinars actually work for you, that would be really helpful to us. Otherwise, have a great evening.